Cardiovascular system infection. Cardiovascular system infection would be divided into two parts, into two lectures. Lecture 1 about endocarditis and lecture 2 about rheumatic fever. Then we start with infective endocarditis. Our ILOs would be by the end of this lecture, we must be able to first identify the etiology, risk factors, pathogenesis, clinical presentation, laboratory diagnosis of infective endocarditis. Then we must be able to put outlined treatment and preventive measures of infective endocarditis. Endocarditis. Endocarditis is an infection of the inner lining of the heart, which is the endocardium. It mainly affecting the valve of the heart due to colonization of a damaged valvular endothelium by circulating pathogens. It mostly affects mitral and aortic valve. Infection of the heart valve is thought to be result from colonization of a damaged valvular endothelium by a circulating pathogen. The smooth endocardium is normally resistant to infection. Endocarditis is an infection of the endocardium surface of the heart, typically on the heart valve, and occurs in a damaged valvular endothelium which occur by circulating pathogen. The source of circulating pathogen may be either endogenous source of infection or exogenous source of infection. We must know who is at risk for developing endocarditis. Endocarditis usually develops in one of the following conditions, which may be first, unsafe intravenous injection, which is an enduring intravenous catheter or intravenous drug use. Also, it can occur in any dental invasive procedure, which is a common procedure and commonly associated with endocarditis, and with colorectal cancer. It occurs also in patients with damaged valve, which is either patients with congenital heart disease and or rheumatic heart disease, which is associated with damaged valve. It may also occur in patients with prosthetic valve or patients with pacemaker or defibrillator. It appears that the circulating bacteria don't readily adherent to the normal endothelial surface. So trauma of the valve, however, produce an alternation in the endothelial cells and leading to either disturbance of the surface or deposition of the platelets and the fibrins or the other phenomena which make the surface susceptible to colonization by a circulating bacteria. Then, once the surface is prepared, some bacterial strains appear to be adherent to fibrin platelet masses. Endocardial damage or injury of the endocardium initiated by pathogenic sequence, which leads to infection. In most of cases, injury is due to maybe hemodynamic trauma associated with localized turbulent flow, such as turbulent flow can occur in the endocardium covering deformed heart valve, or at the endocardial impact size of high velocity inject of the blood. Foreign bodies such as an enduring cardiac catheter or prosthetic heart valve can also initiate endocardial injury. Then bacteria start to be entered, and bacteria found its way through the bloodstream anytime to be colonized on the epithelial surface, which is traumatized surface of the endocardium. Mild, transient episodes of bacteremia likely happen fairly regularly due to everyday activity, such as teeth brushing, or may occur more profoundly following dental procedure, surgical procedure, or intravenous drug abuse. Whatever the case, in most normal patients, these episodes are self-limited and don't lead to endocarditis. However, in individuals with any of these risk factors or pathogenic factors, or patients with congenital or traumatized or rheumatic heart disease with injured valve will be affected, and the bacteria can colonize and proliferate within the adherent thrombi, and in doing so damage the underlying endocardium, as well as physically expand the vegetation. So, any normal flora that can reach the bloodstream can cause effective endocarditis. The organism enters the bloodstream most often at the site of any dental surgery or during intravenous catheter or intravenous drug use. Colonization of the damage, usually the valvular endothelium, by this circulating pathogen, and the adhesion of these bacteria to the damaged endothelium is enhanced by their ability to produce a glycocalyx. Once this infection has begun, a combination of this organism and the thrombi will organize and form a vegetation, and the destruction of the valve occurs at different rates depending on the virulence of the organism. As the valve is destroyed, symptoms of valvular segregation can develop. Also, the vegetation of the valve may be enlarged, and then fragments can spread through the bloodstream and form emboli, which may lead to catastrophic effects such as cerebrovascular accident. As you show, there is often bacterium or two in your bloodstream. This can occur or reach the bloodstream during brushing of your teeth or bath stool. You are going to get a few bacteria into your blood. If you go to the dentist or get catheterized or bronchoscoped or cystoscoped or have a colon cancer, you will get lot more. All of these risks, you are at risk of endocarditis, and if you do intravenous drugs without using aseptic technique, which is a sterile technique, you will begin for trouble. If the endothelium is damaged, tiny amounts of platelets and fibrin clots can form on the valve. This wouldn't be much a problem, and they would probably go away, except for the fact that every once in a while bacterium can get enwrapped in the clot. Once the bacteria has found a place to live under the fibrin, it is protected from the body defense mechanism, and the valve leaflets are by fact that it's avascular and the blood is chamber is flowing too fast to allow neutrophils to stop here. The surrounding endocardium will probably get damaged, and the vegetation can grow. Vegetations can grow, and then this vegetation may be disseminated and form a thrombi, which it can pass through the blood into different parts and form what's called endocarditis. Clinical manifestation. Clinical manifestation of endocarditis depend on virulence of the infected pathogen and the time course of the illness. Infective endocarditis can be either acute endocarditis or subacute endocarditis. First, acute endocarditis. most often occur when an aggressive species of skin bacteria, especially Staphylococcus, enters the bloodstream and attack a normal undamaged heart valve. Once Staphylococcus bacteria begin to multiply inside the heart, they may send small clumps of bacteria, which is called septic emboli, into the bloodstream, and then spread the infection to other organs, especially to the kidney, lungs, and brain. Intravenous drug users are at high risk of acute endocarditis because numerous excessive and repeated needle injections giving aggressive amount of bacteria, which is Staphylococci, enter to the blood. And if untreated well, this will form endocarditis, which is fatal in less than 6 weeks. So, course of acute endocarditis days and with sudden onset, most probably occur by types of bacteria with Staphylococcus aureus, and it usually occurs in normal heart, and patients who are at risk are patients with intravenous drug user with excessive and multiple injections. Second, subacute bacterial endocarditis or subacute endocarditis. It's caused by one of the very dense group of streptococci, which may be streptomutans, streptomyces, or others that normally live in the mouth and throat. Also, Streptococcus bovis and equinus can cause subacute bacterial endocarditis, typically in patients who have some forms of gastrointestinal cancer, usually colon cancer. Subacute bacterial endocarditis tends to involve the heart valve that already are damaged valve, and it is usually less likely to cause septic emboli than acute endocarditis. And if untreated, subacute bacterial endocarditis can worse for as long as 1 year before it becomes fatal and causes death. So the course ends in subacute bacterial endocarditis is weeks to months with a gradual onset, most probably occurred by very dense group of streptococci and usually involves damaged heart valve. The patient with acute endocarditis has no previous heart valve damage, and the most common organism is Staphylococcus aureus from patients with intravenous drug abuse. Subacute bacterial endocarditis, patients usually with previous heart valve damage, and the most probably caused organism is Strep viridans or very dense group of streptococci, or group D streptococci, or maybe Enterococcus, or also Staphylococcus epidermidis, Candida, Aspergillus, Pseudomonas, and very dense group in patients with intravenous drug use. Signs and symptoms are relatively non-specific, and a high degree of clinical suspicion must be employed with an eye towards the risk factors, which is an important and the main rules in diagnosis of acute and subacute bacterial endocarditis. Clinical manifestation of endocarditis. Clinical manifestation of endocarditis starts with constitutional symptoms in the form of fever, which occur more than 80% of cases, chills, night sweats, and anorexia. May be associated with symptoms of consequence of obstruction of heart valve by signs of new murmur and heart failure. In some cases, manifestation due to spread of emboli can occur, which affect the brain and CNS, cause neurological manifestation that we may reach to the eye and causes retinal hemorrhage to the lung, causes pulmonary emboli, or may cause hemorrhage under the nails, which is splinter hemorrhage. In some cases, can be associated with genuine lesion. Manifestation occurs due to antigen-antibody deposition, can be associated with patients with endocarditis in the form of Osler's nodes, or can affect the kidney and causes glomerulonephritis in the form of hematuria or arthritis. endocarditis easily be diagnosed and treated if you think about it. It depends mainly on history from the patient, and patients who are at risk, patients with heart disease, either congenital heart disease or rheumatic heart disease, or patients with traumatic valve. It usually begins when one bacteria finds its way underneath one platelet. Most likely starting places occurs in the deformed surface of the old rheumatic valve, or congenital birth defect, or patient with prosthetic valve, or excessive drug abuse, excessive needle injection, and patient with excessive dental operations. Most probably, one of the most common organisms which found its way to reach the blood may be Enterococcus or Staphylococci. Just it found its way and reached to the affected valve. It starts to be settled in this defective valve and form a mass of fibrins with neutrophils and bacteria on the valve. The location on the endocardium gives the bacteria a strong head to start to form a vegetation, and just this vegetation starts to separate it or segregate it and form an emboli. Patient may be associated with signs of cardiac disease, cardiac failure, with murmur, can be associated with big spleen, or Osler's nose, fever, which is more than 38, or may be associated with neurological manifestation. Microbial etiology of endocarditis. Most cases of infective endocarditis, which is more than 90%, are caused by bacteria, which is a gram-positive bacteria. Likely because gram-negative bacteria and fungi are rapidly destroyed by the plasma membrane protein. So bacteria are the most common cause of endocarditis, but can occur also due to fungal infection by Candida species. The modern classification of pathogen causing endocarditis is divided into native valve versus prosthetic valve endocarditis, with sub-classification within each group. These sub-classification depend on source of pathogen and clinical course. Source of pathogen, which may be endogenous or exogenous pathogen, and also which may be hospital-acquired infection or community-acquired infection. Clinical course, which may be acute course of endocarditis or subacute endocarditis. First, native valve. By subclassification according to the source of pathogen, may be community acquired or healthcare associated. Community acquired caused by virulent streptococci, Staphylococcus aureus, or Enterococcus species. Healthcare associated is caused by Staphylococcus aureus, Enterococcus species, and Staphylococcus epidermidis. Intravenous drug abuse can be caused by Staphylococcus aureus, gram-negative bacilli like Pseudomonas and Serratia, and also can be caused by Candida species. So again, native valve can occur community acquired, healthcare associated, intravenous drug abuse, and the most causative organism for each type. In community acquired native valve, it may be caused by virulent streptococci, Staphylococcus aureus, Enterococcus species. And in healthcare associated, it may be caused by Staphylococcus aureus, Enterococcus species, and Staph epidermidis. Intravenous drug abuse can be caused by Staph aureus, gram-negative bacilli like Pseudomonas and Serratia, and also by Candida species. Second type, which is prosthetic valve, this depends on the course of infection, which may be early or late. Early, usually caused by Staph epidermidis or Staph aureus. Late can be caused by Staphylococcus epidermidis or Staphylococcus aureus, also by very dense streptococci and Enterococcus species. Other causes may be Brucella species or Coxella parenti. So again, second type, which is prosthetic valve, may be early or late or other causes. Early, most probably caused by Staph epidermidis and Staph aureus. Late course may be caused by Staph epidermidis and Staph aureus, or very dense streptococci or Enterococcus species. Other causes may be caused prosthetic valve, which is Brucella species and Coxella parenti. Acute infective endocarditis. In acute infective endocarditis, the most causative organism first may be due to Staphylococcus aureus or Staphylococcus epidermidis and Enterococcus species. Acute infective endocarditis has a rapidly progressive course of bacterial endocarditis, which is occur within days. It is usually fatal within few days if untreated quickly. In acute infective endocarditis, the source of bacterial infection may be exogenous source of infection or may be endogenous source of infection. The organism finds their way from the initial site of infection or colonization to the heart valve through either colonized enduring intravenous catheter or repeated unsafe intravenous injection, or in patients with colorectal cancer, which is the main risk factor for developing acute infective endocarditis. Subacute infective endocarditis. Subacute infective endocarditis is more common and symptoms developed over a longer period. Time of course of illness, weeks to months, which is more than acute infective endocarditis. Its symptoms is usually a non-specific symptom. It occurs with normal commensals, which is present in the upper respiratory tract and the buccal cavity wing, which may enter the blood after one of these procedures, which is tonsillectomy or tooth extraction. Not all patients exposed to tonsillectomy or tooth extraction will develop subacute infective endocarditis. If this person is a healthy individual, such bacteria are cleared from the circulation within few hours or 1 hour. But if the patient has a predisposing factors, predisposing condition such as a disease or artificial prosthetic heart valve, like patients with rheumatic fever, rheumatic valve, or congenital valve disease, patients with prosthetic heart valve, In this case, colonization of the damaged valvular endothelium occurs by this circulating pathogen and causes subacute infective endocarditis. How to diagnose infective endocarditis? In patients with a chronic or subacute presentation, 3 sets of optimally filled blood culture should be taken from the peripheral sites, which usually within equal or more than 6 hours between them, and it usually must be taken or should be taken before the administration of antibiotics. So it's recommended to obtain 3 sets of blood culture over at least an hour, which is equal or more than 6 hours, and this blood culture must be taken before any administration of antibiotics. Taking this blood culture at different times is critical to identify a constant bacteremia, which is the main hallmark of endocarditis, and is the main method for diagnosis of infective endocarditis. Also can be confirmed by ECG, which is an echocardiographic finding, and other clinical criteria, which is modified Dock criteria. We will talk about some important characteristics of common positive agents. And we will talk about it in short. We remember together that gram-positive classified either gram-positive cocci or bacilli. Cocci we classified into staphylococci and streptococci. This depends on the result of catalase test. Catalase positive is the staphylococcus, and catalase negative is the streptococcus. From staphylococci can divide it into 2 types according to coagulase, which is coagulase positive Staphylococcus aureus, or coagulase negative Staphylococcus epidermidis and Staphylococcus saprophytic. Catalase negative cocci is the streptococcal group, which can be divided also according to its effect on the blood, the hemolytic effect on the blood, which may be cause a complete hemolysis like Streptococcus biogenes, group A streptococci, group B streptococci, streptogalaxia. It may cause alpha hemolysis or partial hemolysis like streptoviridans and streptopneumoniae, or maybe non-hemolytic like enterococcus. So flow chart to remember together about gram-positive cocci. Gram-positive cocci by catalase test, either it is positive or negative. If it is positive, then it is a Staphylococcus species. Negative, then it is a Streptococcus species. Staphylococcus species, we do coagulase test. If it is positive, it is a Staphylococcus aureus. And if it is negative, it is a coagulase negative Staphylococcus species, which may be Staph epidermidis or Staph saprophytic. If catalase test is negative, it is a Streptococcus species. So it's grows on sheep's blood agar. If it causes beta hemolysis, which is a complete hemolysis, it may be streptobiogenes. Grows in presence of bacitracin. It is no sensitive, so it is streptobiogenes, which is a group A streptococci. If it is growth occurs in the presence of bacitracin, so means it is a resistant another beta hemolytic streptococci. If it causes a partial or alpha hemolysis in the blood agar, can be may be Streptococcus pneumoniae or other alpha hemolytic streptococci. Can be differentiated by using Optochin disk. If it is no sensitive, non-sensitive, so it is a strep pneumonia. If it is resistant, it is alpha hemolytic, other types of alpha hemolytic streptococci. Staphylococcus aureus. We can remember together some points about Staphylococcus aureus. Staphylococci are classified according to coagulase, as we mentioned before, by coagulase test into coagulase positive staphylococci or coagulase negative staphylococci. Coagulase positive staphylococci, which is Staphylococcus aureus, and coagulase negative staphylococci like Staphylococcus epidermidis. Major characteristic of Staphylococcus aureus, as we show in this slide, it is a gram-positive cocci arranged in chains. Gram-positive cocci arranged in chains. Its effect on blood agar, it causes complete hemolysis or beta hemolysis. It has a beta hemolytic gram-positive cocci. By catalase test, catalase positive, which differentiates staphylococci from streptococci. And by coagulase test, coagulase positive, which differentiates between Staphylococcus aureus and other coagulase negative staphylococci like Staphylococcus epidermidis. By biochemical reaction, it was found that ferment mannitol and on mannitol salt agar. Also, it produces a golden yellow endopigment, which is very characteristic for the growth of these types of bacteria on nutrient agar. It gives a golden yellow endopigment on the surface of the agar. Staphylococcus aureus virulence factor. Virulence factor of Staphylococcus aureus include cell-associated factors, enzymes, and toxins. From these cell-associated factors, maybe cell surface protein or capsule. Cell surface protein like protein A. Protein A, which is present on the cell surface and is bound with Fc region of Ig inhibiting the process of opsonization, so it protects the organism from phagocytosis. Another cell surface protein is lumping factor, which is the bound coagulase. From cell surface factor, capsule. Some strains form a polysaccharide capsule, which has antiphagocytic effect, which is the main virulence factors in organism with capsules. Second, enzymes like coagulase enzyme, which is a free coagulase, and beta-lactamase enzyme, which is penicillinase. Also, from virulence factors, toxins like alpha toxin, which is a hemolytic exotoxin, and BV leukocidin. Second example of a causative organism of endocarditis is Staphylococcus epidermidis. Staphylococcus epidermidis, one of cocci, which is a gram-positive cocci, also arranged in groups, and it is catalase positive to differentiate between Staphylococcus and streptococci, and it is a coagulase negative to differentiate it from Staphylococcus aureus. And the difference is non-hemolytic, has a non-hemolytic effect on the blood agar, and it can be differentiated from other types of coagulase negative staphylococci like Staphylococcus sabrophyticus by using in novobiocin death, in Staphylococcus epidermidis it is sensitive to novobiocin, and in Saprophyticus it is resistant to novobiocin. This pathogen is a normal cutaneous flora. It is opportunized by colonizing the biomedical devices, like patient with intravenous catheter, or patient with shunt, and patient with prosthetic valve. The organism starts to find its way to settle on these devices and form colonization on the device and start to cause infection. This strain has the ability to produce a glycocalyx, which are more liable to adherence to the prosthetic implant material and cause colonization on the surface of this material and start to cause the infection. Another example from causes of endocarditis is enterococci, like Enterococcus faecalis and Enterococcus faecalis. Major characteristics of enterococci is that it is a gram-positive cocci, which is usually arranged in diplococci. It's catalase negative. Group G, streptococcal cell wall carbohydrate antigen, and it is salt and bile tolerant. Also, it's characterized by high pattern antibiotic resistance. So, enterococci are intrinsically resistant to many antibiotics like penicillin, cephalosporins, aminoglycosides, and lincosamide. This plate of antimicrobial sensitivity shows Enterococcus antimicrobial sensitivity, where it was found that it has a high pattern of antibiotic resistance, where they are intrinsically resistant to cephalosporins and clindamycin. Vancomycin resistance enterococci, VRE, usually emerged in patients, especially hospitalized patients with an hospital-acquired infection. And these strains of VRE mainly treated by using linezolid or by using a combination of two streptogramins, namely quinopristine or diflupristine. Enterococci is a natural habitat in the human intestine. They may cause a disease outside the GIT, particularly in hospitalized patients, particularly in patients with immunocompromised patients. So it causes an opportunistic infection in immunocompromised patients. Other causes of endocarditis is virulent streptococci. Main characteristic is that it's a gram-positive cocci which is arranged in short chain. The type of streptococci, so it's a catalase negative, which differentiates it from staphylococci, which is a catalase positive. It's strep virulence, alpha hemolytic streptococci. Its growth on the blood agar causes alpha hemolysis. So it's an alpha hemolytic on the blood agar. To differentiate between it and another types of alpha hemolytic streptococci, which is strep pneumoniae, can be by using to-chain test, as we show in this plate. This plate, we divide it into two parts, right part and left part. In right part is a growth of strep virulence strain, and the left part growth of strep pneumoniae strain. When we put to-chain test, in the right part it show no area of inhibition, so it is resistant, which is strep viridans. But strep pneumoniae, there is an area of inhibition which means that it is insensitive to bupropion. Also, we can differentiate between them by using bile, where Streptococcus viridans is not lysed by bile, while strep pneumoniae is lysed by bile. Strep viridans is a member of the normal resident flora of the oral cavity. How to treat infective endocarditis? Without treatment, endocarditis is always fatal. And as we answered this question before, which is rapidly fatal, acute or subacute? As we told before, acute endocarditis has a sudden onset and it's more fatal if not untreated with. We need proper effective therapy to start for treatment of infective endocarditis. Usually we start with empiric antibiotic therapy, which is chosen based on the most likely infected organism. For example, patient with a history of intravenous drug use has been treated with naftalin or gentamicin to cover for methicillin sensitive staphylococci. In patients with the emergence of MRSA, methicillin resistant staphylococci or penicillin resistant streptococci has led to change the empiric treatment with substitution to vancomycin instead of penicillin antibiotic. So we start our treatment by using empirical antimicrobial cover, which we should be against methicillin resistant staphylococcus aureus and viridans streptococci, enterococci, and gram-negative bacilli. Vancomycin plus either ceftriaxone or gentamicin can be used. Then we start specific therapy, which is targeted therapy, which is depend on the result of culture and sensitivity, the result of antimicrobial susceptibility testing of the isolated organism after we take our sample and do blood culture, and from this blood culture we can identify the organism. Then we do sensitivity for this identified organism. So according to the result of this sensitivity or antimicrobial susceptibility test, we can choose the specific targeted therapy to treat endocarditis. The antibiotic must be bactericidal drug. Also, this antimicrobial therapy for endocarditis usually required for 4 to 6 weeks. In some cases, not enough to use antibiotic for treatment of endocarditis. We need to surgical interference by surgical debridement of the valve associated with this antibiotic therapy is often required for proper treatment of infective endocarditis. Prophylaxis of subacute bacteria endocarditis. Amoxicillin is the prophylaxis of choice for subacute bacterial endocarditis and is usually recommended before certain procedures, like before invasive dental procedures or before surgical procedures involving respiratory mucosa in patients with superior endocarditis or patients with prosthetic heart valve or selected type of congenital heart disease. So amoxicillin is the drug of choice for oral therapy because it is well absorbed from the GIT and provide a high sustained serum concentration during the procedures. All dental procedures that involve the manipulation of gingival tissue or periapical region of teeth or the perforation of the oral mucosa must take prophylaxis before these procedures. This applies to the individuals who undergo an invasive procedures of the respiratory tract also, which involving incision or biopsy of the respiratory mucosa, such as tonsillectomy or adenoidectomy. This prophylaxis is not required for bronchoscopy unless the procedure involves incision of the respiratory tract mucosa. Prophylaxis is not required for bronchoscopy. Also, prophylaxis is not required for normal individuals. It's only needed in patients with predisposing factor, in patients with benign endocarditis, in patients with prosthetic heart valve or selected type of congenital heart disease. Certain congenital heart defects are like cyanotic congenital heart disease, which is a birth defect with oxygen level lower than normal that has not been fully repaired, including children who have had a surgical shunt or with a congenital defect. A congenital heart defect that has been completely repaired with prosthetic material or a device for the first 6 months after the repair procedures. This repaired congenital heart disease with residual defects such as persisting leak or abnormal flow or adjacent to a prosthetic patch or prosthetic device. All of these are considered to be high risk for developing endocarditis, so patients with all these conditions must use prophylactic antibiotic therapy, which is an amoxicillin dose of amoxicillin, oral amoxicillin prophylaxis before this procedure. This is an example of a case which comes after extraction of a wisdom tooth. An 18 years old male student come with fever and chill. The man is known to have congenital heart disease that has been under control, but he developed a new murmur which was heard on his heart. You must know, how would you diagnose the positive organism of this main illness? Thank you.